Kingdom from a place called Huddersfield, which is between Manchester and Leeds. And luckily, I have this, I used to have this view from my theatre. And sometimes having a view like this from your theatre is very important, because when you get stuck, you've got to go and seek for some divine intervention to help you get out of trouble. So if there is a lot of concrete between you and the divine intervention, the waves are altered. So that's what we need to do. These are my disclosures. So far, we all know that total knee replacement, and we've always heard that total knee replacement is a soft tissue procedure with bony cuts. We keep on debating as to whether it should be a gap balancing technique or a measure dissection technique, whether we should use both, either in combination. But the bottom line is you need a well-balanced knee. But often it is not emphasized enough as what the role of the bone is. And I put it to you that the bone is probably an equally important bit as far as the total knee procedure is concerned. It acts as a scaffold, it's base for the implants, and it is responsible for providing the stability to the implants. Bone deficiency in total knee replacement is a frequent problem. The management is controversial, and we can debate about it for long periods of time. And whatever we do, we must realize that if it is not dealt with properly, it is a complete disaster. Patients with severe arthritis, with severe deformity, do have a lot of bone loss or bone deficiency, leading to ligamentous instability, and this ligamentous instability in turn actually causes more bone loss. It's a surgical challenge to us as surgeons. It is technically demanding, and I put it to you that it's extremely important that you must actually assess the situation before embarking upon any form of surgical treatment. The causes of bone loss in the primary setting relates to osteoarthritis, trauma, avascular necrosis. It could just be plain and simple osteopenia and further collapse, rheumatoid arthritis, or as surgeons giving repeated steroid injections could be responsible for it. On the other hand, the revision setting, which seems to be more common, you get osteolysis, bone loss as a result of implant extraction, infection, or fractures. In severe arthritic angular deformities, you see bone defects as a routine. There may be predisposed hyperplasia of the condyles, avascular necrosis, previous trauma, or previous surgery. The location of the bone defects is very important, because knowing and assessing and preoperatively knowing where these bone defects are helps you actually plan the treatment. In a varus knee, classically the bone defects is peripheral and posterior medial. In opposition to that, in valgus knee it is much more central. When there is a peripheral bone loss, there is usually no support to the tibial component, and you need to think as to how you are going to provide that through your surgical procedure. And that may mean that you may need to have some infrastructure organized and have some inventory available. Whereas a central defect does have a cortical rim, which may or may not support the implant, but you need to be aware of that. And finally, just a quick word of previous high tibial osteotomy. In contrast, even if it has gone into failed into varus, you often see a posterolateral deficiency. In the revision scenario, it's completely different. In a uni, it's much more localized. In a total knee replacement, it could be distal and posterior, but on the femoral side, and central or peripheral on the tibial side, depending on how careful you've been and how the implant has actually failed. And if you have a hinge, it is a massive cavitatory type of defect. It is important to know what the bone defects are like, what the area and depth is, which gives you, you get an idea of that based on the duration of the problem, the amount of instability that the patient has got, and the strength of the bone itself. Whether it's just pure eburnated bone or whether it's actually bone loss, it is important to understand. In rheumatoid arthritis particularly, the defects can be central, but you may be surprised that often you get associated medial and lateral defects as well. The types of bone defects is often produced an algorithm as to how you're going to treat them, and that's why this less than 5 millimeters, 5 to 10 and more than 10 millimeters has become important. But perhaps more important is the location of it, as to whether it's central or peripheral, and whether the margins are contained or uncontained. There have been several classifications of bone defects. The one that has been commonly used early on has been Rand's classification, where he divided them into three, type 1, 2 and 3. In type 1 and 2, the cortical rim was intact. there was either a focal or an extensive metaphyseal defect, and in type 3 it was a combination of both. It didn't really help us as far as the further management was concerned. Recently, in the late 90s, arising from the Anderson Institute, the Eng brothers produced the AORI classification of bone defects. And this was based on the type 1 being intact bone, type 2 being deficient, or type 3 being damaged. And when they further classified them, there is F1 and T1, F2 and T2, both A and B, and F3 and T3. The advantage of this is it actually tells you what you can do to get out of trouble, what you need when you to reconstruct the knee, and that is perhaps more important. And therefore today, this is the classification that is commonly used. Having said that, it is really a combination of your initial clinical assessment, preoperatively, and the intraoperative assessment. And I put it to you, whenever you are dealing with bone defects, it is imperative that you have all the armamentaria available to you, depending on the extent of the defect. The surgical challenge that we face relates to bone issues, relates to the soft tissue imbalance. There is always a conflict between how much constraint at what cost in terms of stability. We ought to think about the long-term function, because there's no point in providing a huge amount of stability and then finding that in the long run that implant doesn't work. And in younger patients, as we operate on them more and more, we need to understand the wear rates. And why do we need to know this? Because the intraoperative findings will actually make you decide finally what exactly needs to be done for that patient. Because not only do you need to keep bone loss in mind, you need to wonder and you need to appreciate what the ligament integrity is. That will decide the procedure and the implant. As a matter of routine, my clinical examination under anesthesia becomes very important. I need to assess as to how much correction that can be achieved as far as the deformity is concerned. I'm previously aware of the gait and the thrust, whether this deformity corrects in flexion or extension. Particularly in the valgus knee, if there is valgus in extension and that corrects completely in 90 degrees of flexion, you can safely think that there is no major soft tissue release to be done. It's a pure bony problem, and by actually dealing with the bone with whatever is required, you'll be able to correct it. And the laxity of the ligaments is important to assess, particularly if it comes to a valgus knee and you are unsure of what the status of the medial collateral ligament is. The medial collateral ligament is the cornerstone of any total knee replacement surgery, and if that is deficient, inefficient, and not really functional, then you ought to be putting in a hinge, even if the rest of the bone is good, unless you open up and then reassess the medial collateral ligament again and carry out different kinds of procedures, which are not ideal, but can be done. The imaging is standard. That when you see bone defects, you should not be operating on old X-rays, because you don't want any further surprises than what the knee will throw up anyway. There is a role for CT